We're going to talk today about LSAC, which you might not have heard that acronym before, the Limb Salvage Advisory Council. This is Dr. Shishabor's brainchild. When we talk about multidisciplinary approach, let's see here. Oh, got it. When we look at physicians, groups who treat peripheral vascular disease, you can see there's a Venn diagram here: vascular surgery, interventional cardiology, and interventional radiology. But you have to add in podiatry, cardiac surgery. In some markets are doing bypasses, carotids, endovascular procedures. And then also vascular medicine is involved. And so the appearance of physicians managing PAD can look like 15 hungry puppies around a dog dish. And so how do you really build a multidisciplinary team? There's a lot of discussion and theoretical proposals, but it really depends on the size of the dog dish. So in markets where there is a large dog dish and not too many dogs, people can act as a team and work for the benefit of the patient. Everybody has enough to do, and they can do the procedures that they enjoy doing. However, in certain hyper-competitive markets, when that dog dish is very small, it's every man for himself. And it leads to chaos and no coordination, and the patients end up suffering. So at UH, we've created a multidisciplinary approach to limb salvage involving vascular surgery, cardiology, vascular medicine, and our podiatry and wound care physicians as well, to try to get the best outcome for our patients. And this is not an easy team to build. One of the favorite quotes regarding team building is very apt for peripheral vascular interventionalists treating patients with critical limb ischemia. To build a strong team, you must see someone else's strength as a complement to your weakness and not a threat to your position or authority. And this message sometimes is hard to get across. So we have created a system-wide limb salvage advisory council because the stakes are high. Patients are losing their limbs. This is a huge impact, not just to the patient, but to the healthcare system in general. And it's clear that a multidisciplinary approach is effective in decreasing the risk of amputation. So here is the process flow in our facility, and probably similar in most centers. Primary care, podiatry, or wound centers send the patient for evaluation, for intervention, either with interventional cardiology or perhaps vascular surgery or interventional radiology, depending on your market. And those patients get an intervention. If that intervention is successful, the patient heals and goes on. Or if that is not successful, the end result is a major amputation. So the idea of the Limb Salvage Advisory Committee is to intercept that patient between intervention and amputation. So it is not to advise the physician how to treat the patient. We're not telling our doctors, use atherectomy, don't use DCB, do a bypass. That's all left to the individual discretion of the treating physician. But when that treatment fails or is at risk of failing and the patient's not doing well, before that patient goes on to amputation, the LSAC will be involved. And the members of the committee include vascular surgery, cardiology, vascular medicine, podiatry, and our plastic surgery folks and wound care specialists, all involved, all invited. All of these providers had numerous objections, ideas, criticisms, critiques to the advisory committee. However, as Samuel Johnson said, nothing will ever be attempted if all possible objections must first be overcome. So everyone gave their opinions, and the Amputation Advisory Council was created. We have an IRB for this, the objective being to see, does the LSAC have an impact? Can we intercept these patients and change the outcome for patients at risk for amputation? And so this is the way it works. A patient who is at risk for amputation or who has a planned major amputation activates the LSAC by advising the research coordinator. A case presentation is created by one of our fellows, and then we have a WebEx board meeting. So everybody is notified. We get the patient history and some angiograms, which I will show you in a second. And then everybody talks by phone, come up with an action plan, and then proceed from there. And so here's a sample a PowerPoint presentation put together. It gives the patient some history, some pictures of the wound or foot, the past medical history. Now, these were all put together by the cardiology fellows, and I think they spend a lot of time doing this. It's perhaps overkill. They give the physical exam, they can give some lab values, meds, allergies, x-rays of the foot. We can put in the PVRs, arterial studies, vein mapping, and then the angiograms. And also we have the patient's medical record number and name, and we can go ourselves into the medical record and review the angiograms in more detail if we like. And we're all linked on a computer system. We can do this from home and from any office. Then we all talk, decide what is the next step to go. And so far, we don't have a whole lot of data to show you yet. This is in its infancy. Hopefully by next year, could present some real data. The top reasons for referral so far, incomplete revascularization, especially of the tibio-pedal vessels. So we get the SFA open and maybe the proximal tibials, but the foot is not fed well. Failed surgical bypasses, difficult popliteal and trifurcation occlusions, patients sent for limb flow, and also some patients who have just severe tissue loss where the physicians are suggesting amputation is the only method of treatment. So I think thus far the LSAC and these discussions have really opened, I think, the provider's eyes to what is possible in limb salvage, and has really shown our partners what is possible from different perspectives, from surgery or endovascular, leading to more collaboration. And I'd like to say that this is what the CLI team looks like at university hospitals. It's a work in progress. And of course, right here, we have Mehdi directing the entire enterprise. All right, thank you for the opportunity.